for having me on board. Hello everyone. So these are my disclosures. So first I would like to start the tools that are not for use anymore, even if we have many expectations. And let's go 20 years back with iridium therapy to treat instant restenosis. This was in the late 90s, and we have seen lots of late stent thrombosis, and this led to interruption, of this therapy, which is not available anymore. But we should also think about new devices like bioresorbable stent, for which we have lots of credits, and then when looking at studies, especially randomized trials, late outcome and stent thrombosis, and we had the same story. And probably it's the same local phenomena which is related to a late inflammation leading to the occlusion of the arteries. So the story is not ended yet, but for sure we do not have any more of this device on our shelves. Now we have the devices that are not for routine use, but they are still essential, and I think that they should remain, in the cath lab. And this is first coronary thrombectomy. So although these devices are not for routine use because the randomized trial show no clear-cut benefit, on hard endpoints, but at least what we have seen is that there was better stenting, with shorter stent, and we know that the length of the stent is associated also with late outcome, but there was no benefit with respect to mortality or reinfarction. But anyway, we still have, some patients like this case where we have a big thrombotic burden, in the proximal part of big arteries, like the left main here, where coronary thrombectomy is very useful and save the patient. So we should have, still this device on board, but they are not for routine use, and this is a class 3B recommendation in the guidelines. Now, this is the same for EIBP in the patients who are presenting with cardiogenic shock, which are not related to mechanical complication of myocardial infarction. But we still need to have this device on board, and we need, of course, to track this mechanical complication because they are very useful in that setting. But for cardiogenic shock, which are not related to mechanical complication, it is useless. But in some patients where LVADs may be discussed later on, this could be also a good tool to prevent LV overload. So not for routine use, but you still need to have it around in the cath lab. Okay. So let's move to the essential device for daily practice, the one that you cannot escape from. This is first the fractional flow reserve for routine angioplasty. We have many patients who are coming in the cath lab for angina, but without established proof of ischemia. And we have now lots of evidence that when you have, ischemia proven, especially with FFR, then you improve late outcome of your patients. So I think that we all agree, and all the studies, are very consistent with the benefit of such tool. Now there are also intracoronary imaging, which are very useful, especially for the patients who are presenting with MINOCA, which means myocardial infarction without any obstructive coronary artery disease, and for which you need to have, a diagnostic. And this is here a case of a spontaneous coronary dissection. And when you have the right diagnosis with the right tool, then you know the right treatment. But you have also unsolved issues, for example, late-stage thrombosis, and you need to know what is the underlying reason, whether it is edge dissection, stent malpositioned, or isolated uncovered struts as shown here with the OCT. So I think that we should have this tool available as, you know, routine tools in our cath lab. Now, of course, drug-eluting stents, we all agree that they should be used, you know, for any types of situation, and especially in the most frail patients, irrespective of the anticipated DAP duration. And this is the a very nice study on you know, the comparison between BMS and DS in patients in whom you cannot have sustained DAPT duration given the high bleeding risk, and you can see the benefit of drug-eluting stent. And we have now the third generation of DS with very small thin strut, where you can also expect some more benefit. So these are the recommendations from ESCTS and ESC, and I think that they are very clear-cut. So DS for everyone, irrespective of the clinical presentation, lesion type, planned non-cardiac surgery, anticipated duration of DAPT, and concomitant anticoagulant therapy. So it's very clear and very important. Now, catheter extension is also probably one of the best tools we had since the last 10 years, because, you know, it may change the results of your procedure from, you know, a failure to success. It is not used very frequently, but it is more frequently used in complex lesion in patients with multivessel disease, tortuous and calcified lesion, where, you know, the stent cannot reach the lesion easily. And you can see that the success rate is very high and the complications are very low. We do not have any randomized studies, but we all agree that they should be in the cath lab, and you have all size available from 5 French up to 7 French size. So it's very handy tools. Now, drug-coated balloon is probably very interesting for in-stent restenosis. And we have studies showing the benefit of this device. There is no clear-cut benefit of this device in you know, small arteries with you know, tight lesions, and some are using drug-coated balloon as the first you know, approach, and avoid the use of stent in these small arteries, but we do not have clear-cut evidence for the benefit. But at least for in-stent restenosis, it's a very good you know, approach. Now, the essential devices, but not for routine use. These are you know, the dedicated tools for I would say complex procedures that are not routinely performed, and this is mainly, you know, the specific wires, the microcatheters, the laser device, and the shock waves. So those devices are used for the CTOs or for the you know, complex calcified lesion, and they might be useful, and they are useful, but not for the routine practice. And you can see here an example of how the shockwave device is you know, working when you have you know, a calcification in the media, and you have a resistant lesion to balloon inflation with non-compliant balloon. It may be handy to have these tools. Okay. So now the one that you should think about, this is first, you know, the imaging and multimodal imaging, and we know that many of our cath labs facilities are now hybrid rooms, And we need to, have this image, fusion capabilities in our Cath labs. And I think that because we are now doing structural heart intervention, like, TAVR or occlusion of pattern form and oval, and it's very important to have these modern tools in our Cath labs. And finally, I would like to finish with the physiology, and especially with people who have ischemia without any obstructive coronary artery disease. And we know that it is up now to 30% of our patients who are presenting within the Cath lab with no evidence of obstructive coronary artery disease, but with angina and sometimes documented ischemia, and we need to provide a clear-cut answers to this patient. And I think that we need to have these physiological tools which will assess the microvascular circulation and whether there is some abnormalities with respect to the resistance. And now we have lots of easy tools to assess epicardial flow with the FFR, the RFR, and now we have also specific dedicated tools to evaluate the microvascular stage. And I think that IMR and CFR are very useful tools, as well as absolute flow resistance. And this may end up with dedicated treatment for these patients, and at least they know their diagnosis, and we can adjust the treatment. And I think that this is very important to think about these tools. And this is, for example, the reflow catheter, which also provides a real assessments of the coronary flow and also of the microvascular, resistance. And I think that they are very handy tools, to provide the right answers for the right disease. And I think that many of us are now equipped with this kind of devices. And I think that this is the next step, of the, I would say, modern era of Cath lab facilities. So thank you for your attention, and I'm open for discussion.
Okay, thank you. Thank you very much, Jean-Philippe. We have a few questions coming up, and one from François Schir, who says, what about rotablator?
Of course, rotablator is, part of the Cath lab. I could not address, all the essential tools, but I think that rotablator is about 3 to 5% of our procedures. And there are, of course, essential tools. We do not need, randomized studies to show the benefit of this type of device. The only, I would say, concern is that you need to be trained to use it for the right patient in the right lesions. But it's, of course, an essential tool, and this is a very good question. Thank you, François.
What about cutting balloons? Is that useful, or is it just a joke?
Well, I would say we have some studies showing some benefit, but I think that you really need to plan, your procedure when you're facing a complex lesion. And I think that rotablator is much better than cutting balloon. Even the most I would say modern ones, which have a better profile and who are much easier to use, especially in complex anatomy. But they are not as good as rotablation, in complex lesion where you have calcifications.
A last question, maybe. What is, Jean-Philippe, what is a missing tool? What is the tool that you do not have and would like to have? What is the next frontier?
Well, probably the next frontier would be, to have this bioresorbable stent back in our shelves. but with a much better, you know, safety profile in the long term, you know, because you want to have your arteries looks like before, but without any local inflammation, which may be detrimental, as we have seen.